Hello, everyone. Welcome to today's Research America Alliance member webinar. Thanks for joining us and always for your partnership. We are very happy to have with us today Dr. Josh Gordon. He has been the director of the National Institutes of Mental Health since 2016. It's uncanny, but he was with us exactly 1 year ago, June 1st, 2020. Wow, how much have we all experienced since then? And we know that Dr. Gordon and his colleagues at NIMH have been particularly busy. He's going to speak with us about the Institute's COVID-19 response, the intersection between the pandemic and mental health, and progress against other mental health threats as well. So as usual, type your questions in the Q&A box as we go along, and we will pose them at the end of Dr. Gordon's remarks. Well, Dr. Gordon, a year later, welcome. Thank you so much for joining us today. I'll turn it over to you.
Thanks, Jenny. Appreciate the introduction and appreciate the invitation to come talk to you today. I'm really going to focus my opening remarks on mental health in the era of COVID-19 and talk some about NIMH's and NIH's research in this area. Happy to take questions about anything else at the conclusion of my initial remarks. Next slide. So you all know, but it bears repeating, that mental illnesses are a huge burden, both in the United States and globally. Collectively, mental and substance use disorders account for about 13% of all disability. That's the third leading cause of disability in the United States. It's actually the first leading cause of disability globally. And disability is high, as you know, because mental illnesses strike young and are chronic. Next slide. The COVID-19 pandemic has been, though, at the forefront of our minds for this past year and a half, really. This is a slide, a recent slide, but showing nearly 600,000 people have died from COVID-19. But the impacts of the pandemic have been felt even further than those directly affected by the loss of a loved one or an illness in the family or in themselves. The pandemic has really hit all aspects of our lives, and that has had tremendous impact on mental health. Next slide. We knew that in advance this would be the case. We knew that because of research over the years that NIMH had and others, but have supported, that have shown that most who are exposed to a traumatic experience will have initial symptoms of depression, anxiety, or other stress-related symptoms. And most of those, though, the good news is that the symptoms will improve with time as that trauma exposure lapses and as people recover, sometimes with help and most of the time without. However, a significant minority of individuals will have long-term or chronic experiences with mental illness. And we also knew that social inequalities, health disparities, and individual factors increase the risk of both trauma exposure and subsequent mental health vulnerability. Next slide. Risks for poor outcomes include the nature and severity of the exposure to the trauma, individual differences, including history of trauma, ongoing stressors, substance use, gender, and race. And importantly, environmental factors, including a few social supports and these occupational financial strain. And I want to emphasize that there's no single variable that determines individual outcomes in after exposure to trauma. Next slide. And we also knew from our prior research how to support long-term recovery, including meeting the immediate needs of individuals in practicing healthy coping strategies, treating emerging illnesses, and importantly, finding ways to help others, which promotes a sense of self-efficacy and promotes social connectedness. These factors we've been hawking, if you will, since day one of this pandemic, in concert with lots of private foundations, lots of government agencies really trying to emphasize the need to cope, because we knew that there would be these big mental health impacts. Next slide. Were we right? We can skip this one, actually. Let's go to the next slide. We all know. Were we right? Well, we were right in a number of different ways, but even we were also surprised in some ways by what we found. And the surprise really comes in in the fact that COVID-19, although it's a respiratory illness, turns out to affect the mental health of those who were directly affected by the virus. So this is data from relatively early on in the pandemic, as early as last summer, that showed that individuals who were infected with COVID-19 and hospitalized had higher rates of mood, anxiety, or other psychiatric disorders in the aftermath of that infection compared to individuals with other respiratory illnesses or other causes of hospitalization, and that this post-COVID psychiatric pathology was associated with encephalopathy or confusion during the hospital. So the most severe of cases of COVID. Next slide. So, but what about the rest of us? What about the vast majority of Americans who did not have serious COVID? Were we affected? And the answer, of course, as you know, is yes. Back in June, we knew that 40% of US adults reported struggling with one or more mental health or substance use symptom, including 11% who had seriously considered suicide in the preceding 2 weeks, a remarkably high rate, about triple the normal rate. Next slide. These symptoms that we saw as early as June, these increased rates of symptoms persisted and, if anything, increased throughout the period of the pandemic. This is, again, CDC data published earlier this year, showing that those symptoms, about 40% of Americans reporting something, an anxiety or depressive disorder in the context, the symptoms of anxiety or depression, I should say, in the context of COVID, persisted through January, February. Next slide. There have been more severe outcomes that have been associated with COVID. You all probably know that there was an increase in overdose deaths. This is data from Cook County, Illinois, that we knew early on in the pandemic, but since then, really nationwide. Preliminary data from the CDC shows increases in opiate overdoses for 2020 when they had been on decline from 2018 to 2019. Next slide. Silver lining, or I shouldn't say silver lining, but relatively good news is that we're not seeing yet increases in overall suicide rates in the United States through, for sure, through the summer of last year, and preliminary data through the end of last year suggests that suicide rates overall in the United States have, if anything, decreased in the context of the pandemic. And we might attribute that to a successful delivery of mental health care and crisis intervention services. I can talk about that in the Q&A. Next slide. But we do see pockets of concern. For example, this is data from the state of Maryland showing in orange suicide rates amongst white Marylanders decreasing in the weeks after the shutdown in March of 2020, but suicide rates in Black Marylanders increasing, especially during that shutdown from March to early May. So the most vulnerable of amongst us has seen adverse impacts from mental health, including potentially increases in suicide deaths. And these data really need to be poured over to see if this was a nationwide trend. Next slide. Another surprising effect of the pandemic was, just as I mentioned, of course, that COVID increased the rates of psychiatric illness. Psychiatric illness increased the rates of COVID. That is, if you had a pre-existing psychiatric diagnosis, depending upon the diagnosis, you were anywhere from 3 to 10 times more likely to contract COVID than the general population. And if you were unfortunate enough to contract COVID and had a psychiatric diagnosis, especially schizophrenia, you were up to 3 times more likely to die from COVID than if you didn't have schizophrenia. So we also have to be concerned amongst the vulnerable populations, include those with mental illness, in particular, those with serious mental illness. Next slide. One piece that I mentioned is that we aren't seeing the worst of the possible outcomes from the effects of the pandemic in terms of not increasing suicide rates. One of the potential reasons is the expansion of care that was enabled by federal and state legislation and regulation that allowed the expansion of telehealth. Next slide. We are seeing actual increases in the total number of behavioral health visits in some studies. This is data from federally qualified healthcare centers in California, showing that although primary care visits in orange and behavioral health visits in person in orange, both of those dropped in March of 2020 and through August, the total number of visits in primary care was steady because of an increase mostly in audio or telehealth visits. On the behavioral health side, there was actually an increase in the total number of visits, mental health visits to these federally qualified healthcare centers. Again, because the in-person visits dropped off, there was actually a dramatic increase in both telehealth and video visits, resulting in overall more behavioral health visits in the context of the pandemic. Next slide. We don't know if that data is relevant nationally, but it does look like there was an increase, for example, in calls to crisis centers. So that's what we knew before going into the pandemic. That's what we've learned since gathering data from the pandemic. What are we doing in terms of the COVID-19 relevant research? Well, as you all know, the NIH has a COVID-19 research strategic plan that we are religiously following. A lot of that plan is focused on COVID-19 itself, therapeutic interventions, vaccines, and diagnostics. But next slide, we're also very much concerned about the social, behavioral, and economic impacts of the pandemic. And NIMH, together with several other institutes, has banded together a group to fund first supplements and then original research, really focused on these impacts, and importantly, on interventions that are focused on mitigating those impacts. And I should mention this social, behavioral, economic effects initiative is squarely focused on vulnerable populations, including health disparity populations, rural residents, racial and ethnic minorities, older adults, those with serious mental illness, frontline workers, etc. We funded a lot of impactful research through this work, and we hope to be able to talk to you about that as those results are published in the coming months. Next slide. These are just a list of some of the funding opportunities. I'll just point out a couple of them. Down there at the bottom, you see an emergency ward for social, behavioral, and economic research consortium. This is really aimed at trying to bring together various data sources, including electronic health records, but also records pertaining to social services, et cetera, to try to understand the full impacts of the pandemic. And then the top two ones, both digital and community-based interventions that are aimed at trying to mitigate those impacts. Next slide. NIMH has also been busy on its own, trying to ensure that we understand and attempt to mitigate the impacts of this pandemic. I'll point out one of the various initiatives that are listed on this slide. The second one, notice a special interest. We recognize through the SBE initiative, we had funded a lot of work focused on adults, a lot of work focused on teenagers, and a lot of work focused on early childhood and mother-infant mental health, but relatively little on school-age mental health. And this is an incredibly important issue given the fact that schools were closing, opening, hybrids, all kinds of different impacts. So we've put out a notice of special interest, soliciting applications in that area. Next slide. So I'll just end then with a summary. We knew that that the vast majority of Americans would be affected by this pandemic, that a large fraction of them would be having symptoms as a direct result of exposure to the pandemic, exposure to the mitigation measures, the economic effects. And we expect that some significant fraction of them will have chronic or severe problems that require mental health attention. And what we've focused on through the pandemic is identifying whether we were right, and it turns out it does look like we were right with these predictions, but also applying research to understand what are the best ways to intervene to mitigate those impacts, and those studies are ongoing. And in the meantime, we've been messaging, as I mentioned earlier, on promoting resilience. And with that, I'll leave it up to you to ask questions and make comments. I'm happy to really talk about anything that we have going on at NIMH, including COVID-19 and other research as well.
Thank you, Dr. Gordon. Not surprisingly, you and your colleagues have been tremendously busy. I'm going to start off with a question. You mentioned the higher suicide rates among Black Americans who were disproportionately impacted by the pandemic. And I'm not a psychiatrist by any stretch, but if one was in a community where there was a very high rate of illness and death due to COVID, I could almost imagine almost a post-traumatic stress type of reaction afterward. And are you seeing that among people of color, people in rural areas, those communities that just had really terrible rates of COVID deaths?
Absolutely, we are seeing significant increases in various symptoms of mental illness in vulnerable populations, like you've described, in the populations that have been hardest hit by the pandemic. I can't affirm that we have seen increases in rates of diagnoses like PTSD, et cetera, because those studies require much more in-depth efforts to uncover whether people are meeting, official diagnoses for PTSD. But that's almost a gimme. I mean, it's almost a given, I should say, that we are going to see increased rates of PTSD, increased rates of depression and anxiety disorders. How significant an increase, how long lasting an increase, we don't know. But those populations that you identified that have been hardest hit by the pandemic are also the populations that have a lot of the risk factors for severity and chronicity that I was mentioning at the outset. There are some known mitigations that have probably reduced those impacts. And there's some preliminary evidence that that's the case. For example, we see lower rates of these symptoms in individuals within these populations who received free groceries or free meals, which a lot of communities were offering, compared to those who did not receive those social supports. So we are hopeful that things like the increase in unemployment benefits, the eviction blockade, and the food supports may have had some effect to mitigate those adverse impacts in the populations that were able to access those benefits.
Thank you. I'm going to turn it over to my colleague, Sophia Casca, who is going to look at the Q&A, the cues that have been submitted by our audience. Sophia?
Thanks, Jenny. Our first question is, Dr. Gordon, you mentioned that the new NIMH grant, there has been a lot of discussion about how the pandemic has disrupted children's education due to the switch to remote learning. Is there research being done on the developmental or psychological impacts of social isolation in general, especially on younger children? And what about the pandemic's effects on teachers?
It's all great questions. I believe we have one or two supplements that are funded to focus on teachers in amongst either in isolation or including other frontline workers, and we define that pretty broadly, including grocery clerks and delivery workers, as well as healthcare workers. So I believe that we have teachers included in some of those studies, but I don't think I've seen any results yet on that. In terms of the effects on children, we are going to be very well situated to be able to answer that definitively in teenagers, and because of some studies that we have ongoing, longitudinal studies like the ABCD study, the Adolescent Brain and Cognitive Development Study, as well as in early infants, where we funded a number of cohorts as well already, and those cohorts have been able to include very young children. The reason why we put out the announcement for school-age children is I don't think we have enough studies in that regard. The CDC has already published some data, and we have seen some data that show that children have been adversely impacted during the pandemic in terms of increased symptoms like acting out and increased social isolation. But we don't yet know the full impact, and we don't yet know the results of the differential results of returning to school versus hybrid learning versus exclusively at home learning, for example. And these are questions that we think it's really important to answer, maybe less so now with most school systems planning on reopening fully in the fall. But definitively for unfortunately, we can anticipate that this may happen again. And we want policymakers to be able to understand the full implications of their policy decisions. Yes, of course, you're closing down schools to protect the populace. What are the effects on kids? And then what mental health wise, development wise, psychology wise? And the answer, the implied question there was, are you just looking at mental health outcomes? No, we're collaborating with our colleagues at the National Institute of Child Health and Human Development to ensure that we are measuring developmental outcomes, psychological outcomes, et cetera.
Thank you, Dr. Gordon. Our next question is, what institutional federal policy changes can be made to improve mental health during times like the pandemic where there are additional stressors?
That's a great question. And let me just say at the outset that one of the most important ones was made, right? And that was enhancing access by expanding telehealth, allowing doctors who hadn't made the full transition yet to HIPAA compliant platforms to use Zoom, to use FaceTime, to use whatever they could to be able to reach their patients. That was really, really important. And it's going to be important to help doctors make the transition to HIPAA compliant platforms so that can stay as an access point. My colleagues that I've talked to, this is anecdotal, I haven't seen data, but my colleagues talk, well, I showed you some data about increased numbers of visits. My colleagues who are in private practice say, their no-shows plummeted to zero, basically, because when people don't have to worry about getting caught in traffic, they don't have to worry about getting a babysitter, they were able to show up. There are some disadvantages. We still need to support in-person visits, but it was very helpful to be able to do that. And one area, of course, that was perhaps most impacted is the ability to give daily observed therapy for medication-assisted therapy for substance abuse. They're going to need to figure out a policy approach to that. That's something that we need to think of in the future. I think another step that has been taken more recently is to enhance the funding for community-based mental health services through SAMHSA. Part of the congressional appropriations that were made over the last few months gave several $1 billion to SAMHSA. That's a really positive move. It's going to help shore up mental health access for those who can't afford it individually. And then I think also we need to recognize that parity for mental health care is not something that has been universally achieved in the United States. And ensuring that people can get the care that they need when they need it is really important. And then finally, crisis intervention services are really important. We now have the creation of a national 988 line by Congress. We need states and local governments to be able to fund crisis intervention services so that appropriate mental health professionals get called when someone's having a mental health crisis. And the reason why I link that all to the pandemic is that's what you see during a pandemic. We're seeing increased calls to crisis intervention lines. We're seeing increased need for outpatient services that haven't always been covered with parity. We're seeing a lot of that need rise in the context of the pandemic, and we want to make sure that policies are in place to ensure that those needs are met.
Hey, Sophia, I'm just going to jump in and follow up on that point, Dr. Gordon. I mean, in many ways, it's positive that there's increased access to care. And if we can get additional funding for community mental health services, terrific. How does that impact the human resource side? So do we need to fund more training for professionals in the mental health arena? Will we have enough people who are trained? And if not, how can we encourage more people to go into these fields?
Yeah, so this is a little bit out of the realm of NIMH and more into the realm of other federal agencies, but my understanding is that there is a shortage of service providers in mental health. Of course, it's geographic, like many other areas of medicine where we don't have enough in rural areas, et cetera. But it's more than geographic in the case of mental health. I think there are fewer providers than we need overall, but especially for child psychology, child psychiatry, really, really very few providers per person, even in urban areas. But exactly the balance and how many we need, I don't know, but I think it's generally recognized that there is an undersupply. What policy decisions need to be made to remedy that? I don't know. Do you need to pay for the training, or you just need to achieve parity so that people actually can make a living doing these things? I don't know, but those are great questions.
Thank you. Sophia, we have time for a couple more from our audience.
Our next audience question is, in terms of schizophrenia, is there research or a theory regarding the disproportionate rates of COVID-19 deaths? Is it delayed access to care or a higher rate of comorbidities?
So those are two excellent theories. I'm sure that the latter, that is the higher rate of comorbidities, is playing a role. But the numbers that I cited, it's something like 2.8-fold increased risk of death if you have schizophrenia compared to not. That's controlling for the known comorbidities. So that's controlling for obesity, that's controlling for heart disease and hypertension, et cetera. So, and it's controlling for smoking status. As you know, most people with schizophrenia smoke, and that's a risk factor. So there's something else. Now, there I would be willing to bet that the first hypothesis is playing a big role. That is delayed access to care, and possibly also poorer care once they do receive care, because it is often, unfortunately, the case that individuals with mental illness for one or more reasons receive substandard care, whether it's inability for the doctors to understand what's going on, or perceived inability for their therapeutics to help these individuals. I don't know. So I think those are two potential reasons. There may also be biological reasons. We don't know, but I think those are two big reasons: the comorbidities and then access to care. A lot of individuals who have serious mental illness and schizophrenia, a lot of them are in prisons. A lot of them are homeless. That may also be contributing to higher mortality rates. Perhaps in those situations, and not only are they more vulnerable, but they also may be exposed to higher titers of et cetera, in these communal settings that they are in.
Thank you. It looks like we have time for one more question. So our audience member asks, is there any research going on or planned regarding workplace health as the natural experiment of returning to work goes forward? To be clear, workplaces that shut down during the pandemic and are now returning.
Yeah, that's a really great question. I have the same sort of question also about schools, as they return. The answer is yes. There are research projects that we're funding that will be able to look at these issues. Again, we focused mostly on trying to understand schools because there are big policy decisions to be made there. That not that there aren't with workplace return, but workplace return to some extent has some built-in ways of approaching that with EAPs, et cetera, depending upon the process. So we do have some research equities in this area. I think everybody assumes that, oh, we're going to get back to normal and everyone will be happy. I shouldn't say everybody, that many, and especially many in leadership roles may assume that. But as the question indicates, a lot of people are going to be very, very nervous, very, very anxious, very, very concerned and uncomfortable about returning to the workplace, while other individuals are going to be raring, ready to go. And how you can combine those two types of individuals in a healthy work environment over the next few months, as mask mandates get lifted and as we return to a workplace that's not set up for good social distancing, et cetera. These are really important factors to evaluate. Of course, we're going to be paying attention to infection rates and COVID and make sure that that doesn't go back up. But I think you can also anticipate a lot of mental health symptoms be evoked in that context. And so watching that and being careful for that is going to be really important.
Dr. Gordon, I think this also connects to the point you just made, which is about suicide rates. So
yeah,
they stayed constant during the pandemic, did not climb as they would have otherwise. What do we think is going to happen as we go back to normal? And how can we not let an increase be a foregone conclusion? So to your point about how people will be reacting to going back to normal.
It's a great question. So let me first correct a slight misunderstanding. So we had seen suicide rates rising every year from 2000 through 2018. In 2019, suicide rates went down ever so slightly nationwide. This is before the pandemic, obviously. And so it may be that the decrease that we're seeing in 2020, which is also very slight, is just a continuation of 2019, or it could be an interaction with the pandemic. So let me just start there. But I think you're right. A lot of us are concerned that as the pandemic resolves, as the physical pandemic resolves, the mental health pandemic or the mental health effects of the pandemic may actually increase for lots of complex reasons, including, yes, people are returning to work, they're returning to school, they're returning to the stresses of work and school. A lot of the economic protections are going to be lifted eventually. In fact, I may be already. The eviction prohibitions are being lifted, et cetera. So people are going to be faced with stresses that they weren't before. And then also there's this during a traumatic event itself, there's this sense that, okay, I've got to take care of, food, I've got to take care of shelter, I've got to take care of clothing. And once those are taken care of, you're okay. And it's only afterwards where you return to concerns outside of those three main areas where you see a lot of the mental health effects, unfortunately, increasing. So we are concerned about the possibility that we'll see increased rates of suicide over the next few weeks and months as we emerge from this. And we have to watch out for it. Now, how do we stem that? I think a lot of the same things that we did before, a lot of coping, a lot of connection to care, a lot of crisis intervention services. And for employers and schools, a lot of flexibility for individuals who are going to have challenges returning to work and returning to school full time and with the same sort of level of density.
Thank you, Dr. Gordon. Your last point in particular is just a reminder of, we are still in a very tenuous position, and we need to really look out for our friends and our neighbors and make sure that people continue to have the social as well as psychological support that they need to get through this time. But thank you so much. This has really been interesting and an important conversation.
My pleasure. Thanks for having me.
Okay, great. Just a few quick reminders. On Thursday, June 10th at 11, we are going to have an Alliance member roundtable on ARPA-H. We've heard from a number of our Alliance members that they would really like to talk to other Alliance members about their perspectives on the ARPA-H proposal. What do people think are the key factors that will determine the role that ARPA-H plays to advance medical progress? So it would be great if you can join us to share your thoughts and ideas. There should be a link in the chat where you can register. And if you have any questions in the meantime, please don't hesitate to reach out to me or Ellie Dahoney. Well, we hope to see you then and at future Alliance member webinars. And until then, have a great rest of the day. Thank you.